Hello and welcome back to the Biochemistry for Health Sciences channel. In today's video, we shall discuss the BUN creatinine ratio. In the last two videos, we discussed the urea nitrogen or the blood urea nitrogen, BUN, also called the serum urea concentration, as well as the serum creatinine concentration. Now, if we divide by the BUN by the creatinine, we then get the BUN creatinine ratio. The normal range for BUN, you can see, is about 10 to 20 milligrams per deciliter. That's about 3.5 to 7 millimolar. For creatinine, it's about 0.7 to 1.3, so that's about 1 milligram per deciliter. So that's 0.09 millimolar. And these values vary a little bit from lab to lab depending on the methodology that they use for analyzing the serum urea or the creatinine. So this BUN creatinine ratio normal range is about 10 to 20 when we express the values in milligrams per deciliter. So in case of this patient here, the creatinine is 1.28, the BUN is 15, so 15 divided by 1.28, that gives us a ratio of 11.7. So clearly the concentration of urea is higher in the serum than is the concentration of creatinine, and that's why this ratio is 10 to 20. Now, it's important to note that although urea as well as creatinine are nitrogenous waste products, the BUN creatinine ratio is greater than 1. That means the concentration of urea is much higher than the concentration of creatinine. And one of the reasons for that is urea is filtered, secreted, and reabsorbed. However, creatinine is filtered by the kidneys. There is some secretion, but there is no reabsorption. This means the concentration of urea, because of the reabsorption, the concentration of urea in the bloodstream is going to be higher compared to the concentration of creatinine in the bloodstream, because creatinine is not reabsorbed, is excreted more than urea. So let's look at some of the more important clinical applications of this BUN creatinine ratio, and we'll discuss mainly three important applications. One is in acute kidney injury, the other is in patients with heart failure, and the third is in patients with GI bleeding. Now, acute kidney injury, or AKI, is a common reversible condition in hospitalized patients, and it's associated with a high mortality. The causes of AKI are divided into three groups. One is pre-renal, that means the cause is before the kidneys. The second is renal, that means the condition is due to the kidneys itself. And the third is post-renal, so it's a condition that's happening because of something after the kidneys. Now, this A and B, the pre-renal and intrarenal, account for almost 70% of all acute kidney injury cases. So in pre-renal AKI, there is reduced perfusion to the kidneys. There's a reduced blood flow to the kidneys. Now, this can happen due to many different reasons. One is volume depletion or hypovolemia. In this case, there is a loss of total body fluids, and this is the most common cause of pre-renal AKI, which is also known as pre-renal azotemia or PRA. So one of the most common causes of PRA is hypovolemia, loss of total body fluids. Now, we could lose body fluids through severe blood loss or hemorrhage. We could lose it through the gastrointestinal system, for example, in severe vomiting and diarrhea. We could lose body fluids from the skin, for example, in extensive burns as well as excessive sweating. Or we could lose fluids from the kidneys, for example, in the overuse of diuretic drugs, and in the case of diabetes when we lose water because of osmotic diuresis. Another reason for pre-renal AKI is decreased effective circulating volume. So for example, when the heart is not functioning properly, for example, in heart failure or in myocardial infarction, in heart attack, the heart is not functioning properly, so there is a reduced cardiac output. So if there's a reduced cardiac output, that means there is less blood that is flowing to the kidneys per minute. In case of cirrhosis, the circulatory fluid actually shifts from the blood vessels into the abdominal cavity, what we call ascites, and that will also lead to decreased effective circulating volume. In case of sepsis or conditions like anaphylaxis, there is vasodilation all over, systemic vasodilation, and when you increase the blood vessel volume, the size, the pressure decreases. So basically the pressure to filter blood through the glomerular filtration membrane is reduced, and that reduces the filtration of blood, or the GFR in the kidneys. And then there could be local renal vascular changes. For example, medications such as NSAIDs, they block prostaglandins, and these prostaglandins keep the arterioles open, and without the prostaglandins, there is narrowing of the kidney arteries. So all of these pre-renal conditions are things that are happening before the kidneys. And then there are conditions that cause what's called intrarenal AKI, or intrinsic acute kidney injury. So in this case, the actual kidney tissue is being destroyed. There is damage to structures of the nephrons. For example, blood vessels may be damaged, or glomerulus may be damaged, or the tubules may be damaged, or the interstitium could be damaged. The most common is acute tubular necrosis, also called ATN. ATN is the most common reason or condition that causes intrinsic or intrarenal acute kidney injury. The common causes of ATN include ischemia, lack of blood flow due to shock or dehydration, or a blockage such as clots, as well as nephrotoxins. So a lot of chemicals end up in the kidneys because the body is trying to get rid of these foreign chemicals, so it's done mostly by the kidneys. So they end up in the kidneys, and some of these chemicals are very toxic to the kidneys. Example, aminoglycoside drugs, the iodinated, as well as the gadolinium-based contrast dyes that are used for X-rays as well as MRIs, myoglobin that can be released when a lot of muscle cells are broken down in rhabdomyolysis. This myoglobin is filtered, enters the tubules, and there it can precipitate and cause all kinds of blockages. Then the third type is post-renal acute kidney injury, and this is due to blockage in the urinary tract, either blockage in both the ureters, the bladder, the urethra, and in this case there is an obstruction to urine flow, and that leads to urine backup. The pressure builds up, and that eventually will damage the kidney. And we see this happening, for example, in enlarged prostate, benign prostatic hyperplasia or BPH that will obstruct the urethra. Kidney stones can obstruct the ureters or bladder, and then there could be tumors either in the prostate, bladder, cervix, or the pelvic region, and all of these can obstruct urine flow. So that's why it's called post, after the kidneys. So one of the important applications of the BUN creatinine ratio is to distinguish pre-renal AKI, that's the pre-renal azotemia, from intra-renal, especially acute tubular necrosis. Now, this is important because early diagnosis of the cause of ATN is important because fluid therapy may improve the pre-renal azotemia. However, fluid therapy will cause edema and worsen ATN, acute tubular necrosis. So it's very important to distinguish early on whether a patient is having PRA or patient is having ATN. In addition, ATN has a worse prognosis than PRA. So if we could differentiate these two, we can get an idea of the prognosis of for the patient. So how do we differentiate the two? In case of pre-renal AKI, the causes of pre-renal AKI, we see BUN creatinine ratio greater than 20. However, in case of intra-renal AKI, the BUN creatinine ratio is either less than 10, so it's on the low side, or it could be in the normal range. So high here, in case of pre-renal AKI, normal, or low in case of renal AKI. So let's see why is the ratio high in case of pre-renal AKI. So in pre-renal AKI, there is reduced perfusion to the kidneys. So that means the blood volume is low, and when the volume is low, the pressure is low. So the amount of blood that is being filtered is going to go down. That means the GFR is going to go down, and that would increase the serum creatinine as well as BUN. Now, the body will respond to this low blood volume and pressure. There are baroreceptors that are present in the carotid arteries, in the aortic arch, as well as in the atria of the heart. And these receptors, because of the low pressure, there is less stretch of the blood vessels where these baroreceptors are located. So these baroreceptors sense the decreased stretch of the blood vessels. The baroreceptors will now send signals to the hypothalamus via the vagus as well as the glossopharyngeal nerve, and it will trigger the hypothalamus to make more antidiuretic hormone, which is then sent to the pituitary gland, and from the pituitary gland the ADH will now enter the bloodstream. The ADH will go to the kidneys, and in the collecting duct, the ADH will cause increased reabsorption of water, and in the inner medulla, the ADH will cause increased reabsorption of urea. So more and more urea gets absorbed. So now urea, because of urea reabsorption, the serum BUN will be higher than the serum creatinine, and that will give us a BUN creatinine ratio greater than 20. Now, in case of intrinsic renal AKI, such as acute tubular necrosis, the tubules are damaged, so they cannot reabsorb this water or the urea, and in this case, the BUN does not increase as much as what we saw in pre-renal AKI. So there is increase in BUN as well as creatinine, but the ratio remains either normal or even less than 10. It should be noted that although the BUN creatinine ratio has been used for a long time to distinguish PRA from ATN, several studies suggest that the BUN creatinine ratio is not reliable for distinguishing pre-renal AKI from renal AKI. These studies suggest that BUN creatinine is actually more useful as a prognostic indicator of mortality, but it should not be used to distinguish PRA from ATN. Another application of the BUN creatinine ratio is in heart failure patients. Now, the heart and kidney functions are closely related in health and disease. The impaired function of one organ will affect the function of the other organ, and this is sometimes referred to as the cardiorenal syndrome. Many heart failure patients, about 60% or so, have some sort of renal dysfunction that increases the morbidity as well as the mortality. So in this case, the BUN creatinine ratio is a prognostic indicator for these heart failure patients. The higher the BUN creatinine ratio in these patients, the greater the risk of worsening renal impairment and mortality. So that's how this BUN creatinine ratio helps in evaluating heart failure patients. The third application is in patients with GI bleeding. So when there is blood loss, in this case blood is being lost from the gastrointestinal tract, there is going to be hypovolemia. And what we discussed for pre-renal AKI, that's going to happen here too. The BUN creatinine ratio is going to increase greater than 20. Now, besides the hypovolemia, so here we have blood coming out into the GI cavity. So there is a lot of protein in blood. So basically, this protein is going to be digested by the GI tract, and it is going to, the amino acids are going to enter the liver, and there will be increased catabolism of these amino acids, and that is going to produce more and more urea. And this is going to increase the BUN. So in lower GI bleed, the ratio is more than 20 due to this hypovolemia. But in upper GI bleed, above the duodenum jejunum junction, where amino acid absorption happens, in this case, because of this situation here, the ratio is going to be very high, as much as greater than 30. So in this case, the BUN creatinine ratio helps the physician evaluate whether it's a lower GI bleed or an upper GI bleed. So these are the three most important applications of the BUN creatinine ratio in the clinical setting. The BUN creatinine ratio may also be helpful in other diseases as well as conditions. So let's look at the BUN creatinine ratio in other renal conditions such as post-renal AKI as well as chronic kidney disease. So in post-renal AKI, there is an obstruction of urine flow due to stones, tumors, prostate enlargement. So if the urine doesn't flow out, there's going to be hydrostatic back pressure due to the urine accumulation, and that's going to is going to decrease the filtration, the glomerular filtration rate. And once again, this is going to cause increase in BUN as well as serum creatinine. But because of reabsorption, the BUN is going to be greater than creatinine. And so in the early stages of obstruction, we can expect the ratio to be greater than 20. However, if this obstruction persists, then the pressure, chronic pressure can lead to damage of the tubular epithelial cells, and now the urea reabsorption will be affected. And in this case, the BUN creatinine ratio could either be normal or low. In chronic kidney disease, the filtration is affected, so that's going to increase the BUN and creatinine in the bloodstream, but the urea reabsorption will also be affected. So in this case, the BUN will not be increased as much as in pre-renal AKI. So what we see here is a normal ratio, since the urea reabsorption is also being affected. Now let's look at a few examples of non-renal causes of high ratio. We'll look at high protein intake, catabolic state, as well as decreased muscle mass, and why do these conditions increase the ratio. In high protein intake, for example, a ketogenic diet or excessive protein supplements, as well as what we talked about in GI bleeding. So there's a lot of proteins coming from the GI tract, which means when the liver catabolizes these proteins, it's going to give you a lot of ammonia. The ammonia has to be detoxified to form a lot of urea, so there's going to be increased urea production, which is going to increase the BUN and therefore increase the ratio. Catabolic state such as trauma, burns, major surgeries, starvations, severe infections, stress hormones that increase protein catabolism, drugs such as cortisol that can increase muscle breakdown. In all these cases, there is increased protein catabolism. So once again, there is increased urea production, which increases the serum BUN, and that causes an increased BUN creatinine ratio. Now, in conditions of decreased muscle mass such as aging, muscle disease, less muscle means there's less creatinine as well as creatinine production. And so in this case, because of the decreased serum creatinine, because less creatinine is coming into the bloodstream, but the BUN is normal, so this is going to give you an increased ratio. So using the same reasoning as we did for other conditions, what do you think will happen to the BUN creatinine ratio in a patient that has only Graves' disease? So Graves' disease is one of the most common causes of hyperthyroidism. Okay, high levels of thyroid hormones in the bloodstream. So what would high levels of thyroid hormones in the blood, how would that affect the BUN creatinine ratio? So think about it. You can pause the video and think about what you think might happen to the BUN creatinine ratio. So let's see what happens now. High thyroid hormones, hyperthyroidism, puts a person in a hypermetabolic state. It basically increases metabolism, and that leads to increased protein breakdown. Okay, and because more amino acids are being broken down, catabolism of amino acids, that's going to increase your urea synthesis by the liver. So the BUN is going to increase. BUN is going to increase. Now, patients with Graves' disease, high thyroid because of high metabolic state, a lot of protein breakdown, they tend to be thinner people, weight loss, and they have much lower muscle mass. Okay, very low muscle mass, and that means less creatinine is being produced because there's less muscle. So the creatinine is going to go down. Okay, so BUN goes up, creatinine goes down, and that leads to a increased BUN creatinine ratio. Besides that, thyroid hormones also increase GFR. Okay, so there is increased creatinine urea excretion as well as urea reabsorption, as well as increased creatinine secretion. So all of this is going to increase the BUN creatinine ratio in a patient with Graves' disease. Okay, so this is a few important points about the BUN creatinine ratio. So in the next video, we're going to go down this list and we are going to talk about calcium. So until the next video, once again, thank you very much for watching and supporting this channel. And have a wonderful, wonderful day, and we'll see you in the next video.